eye to eye with thyroid eye disease.
Who gets thyroid eye disease and why? Hi, Dr. Charles Soparker here with Section 3 of PESA Productions' video series on thyroid eye disease. In Section 1, we reviewed some basic concepts about the thyroid gland and thyroid hormones. In Section 2, we discussed autoimmune diseases and defined thyroid eye disease. In this section, Section 3, we explain who is at risk for thyroid eye disease and why some people at risk get it while others don't. The material in this series is meant to be easily understood. Parts, however, may be somewhat dense, and you may wish to review particular sections. If you have suggestions on how to improve this series, we welcome your comments. You may find us on the web at www.plasticeyesurgery.com, email us at info@pesahouston.com, write to us at Plastic Eye Surgery Associates, 3730 Kirby Drive, Suite 900, Houston, Texas 77098, or telephone us at 713-795-0705. Who gets thyroid eye disease and why? Thyroid eye disease is a very common condition. Now, many people are often surprised to hear me say that because people who have thyroid eye disease don't think that they know anyone else who's got this problem. However, the more you know, the more you look, and the more you look, the more you see. Some reports, like the NANES 3 study, have found that perhaps as many as nearly 25% of people over the age of 12 may have an abnormal thyroid problem. A commonly reported figure is 1 out of every 10 women in the U.S. by the age of 50 have a recognized thyroid hormone level abnormality at that time. A lot of data suggests that the real number may be far higher, perhaps over 25%. As we explained in Section 2, at least 1/3 of people with a documented thyroid hormone abnormality will have some manifestations of thyroid eye disease. And perhaps as many as 5% of those will have vision-threatening disease. Nearly 1/5, or 20%, of all women seeking cosmetic consultation in our practice have thyroid eye disease. So thyroid eye disease is probably much more common than you thought. At what age does thyroid eye disease commonly occur? Thyroid eye disease may become apparent at any age, although the likelihood increases with age and peaks between the 6th and 8th decades of life. Newborns who demonstrate thyroid eye disease do so as a result of their mother's autoimmune antibodies crossing the placenta. Infants continue to receive maternal antibodies through breast milk, but by 2 to 3 months of age they begin to make their own antibodies, and they do so robustly by age 6 months. There is a gender bias with thyroid eye disease, as is seen with essentially all of the autoimmune disorders. Females tend to have the disorder more frequently than males. Reports vary, placing females between 4 and 7 times as likely as males to show the disease, and most physicians in the field like to say the rate is 5 to 1, which is consistent with what we have seen in our experience of over 7,000 patients. Although thyroid eye disease is more common among females, don't forget that males get it also. And although they may have just as wide a range of disease expression as females, overall, males tend to have a worse form of the disease. So what determines who gets thyroid eye disease? It appears that first and foremost there needs to be a genetic predisposition, and as might be expected, this predisposition is usually inherited. Secondly, some environmental factors or factor turns on the disease. Let's first discuss inherited predisposition. Most often, autoimmune thyroid disorders are inherited in an autosomal dominant fashion. We'll discuss more about this later, but this means that all first-degree relatives have at least a 50% chance of inheriting the chance of getting autoimmune disorder. First-degree relatives include parents, siblings, and offspring. To understand the inheritance of thyroid eye disease, let's review some very basic genetics. All humans are formed by a coalescence of a sperm and an egg. When these two merge, each carries a single copy of the DNA that is required in duplicate in the final embryo. Here is the genetic material from a human cell. Each cell contains DNA that is packaged into 23 pairs of chromosomes, 22 so-called somatic pairs, numbered as you see them, and 1 pair of sex chromosomes. In this case, the sex chromosomes are an X and a Y chromosome, so this genetic material is from a male. A female, of course, would have two X chromosomes. In each of these pairs of chromosomes, one of the chromosomes came from the mother's egg and one from the father's sperm. Many human traits, such as height, for example, are determined by multiple genes on multiple chromosomes, as well as environmental factors. For simplicity, however, assume that a trait, such as, say, eye color, is determined by a single section of DNA, say on chromosome pair number 15. Half of the DNA determining eye color thus comes from mom, and half comes from dad, since both parents have contributed a chromosome number 15. Here are two parents, both of whom carry genes for eye color on chromosome 15. The mother has blue eyes, with both of her chromosomes having DNA for blue eyes. The father has DNA for blue eyes on one of his chromosomes, but DNA for brown eyes on his other chromosome. He has brown eyes. Thus we say that brown eyes are dominant over blue eyes. If a person has the DNA for both blue and brown eyes, the dominant brown eye DNA determines the final eye color. Only if a person has DNA for only blue eyes does that person actually have blue eyes. Since mom has only blue eye DNA, all of her children will get a chromosome from her that has blue eye DNA. Half of her children will get one chromosome, and the other half will get the other. Dad is a different story. He has brown eye DNA on one of his chromosomes and blue eye DNA on the other. Half of his children will get brown eye DNA, and half will get blue eye DNA. All of the children that have blue eye DNA from dad will have blue eyes, because the other chromosome from mom has blue eye DNA as well. But all of the children who receive brown eye DNA from dad will have brown eyes. Thus, roughly half the children from this couple will have brown eyes, and half will have blue eyes. If dad had two chromosomes with brown eye DNA, then all, or 100% of his children, would get brown eye DNA and have brown eyes. Unless we know specifically what DNA determines eye color and can look for that DNA sequence in dad's chromosomes, we can't tell by looking at dad whether he has one chromosome or two that carry the DNA for brown eyes, because dad has brown eyes regardless of how many of his chromosomes carry the brown eye DNA. If instead of brown eye DNA in dad, we're talking about a gene that turns on thyroid eye disease, and thyroid eye disease is dominant, and other factors such as other DNA and environmental exposures don't play a role, then half of dad's children, or 50%, will have thyroid eye disease. We say that each of his children have at least a 50% chance of inheriting the DNA for thyroid eye disease, because if both of dad's chromosomes are carrying DNA for thyroid eye disease, then each of his children have a 100% chance of inheriting the DNA. For a disorder to be inherited, it means that the vast majority of cases it was passed down through the mother, the father, or both. Neither parent may have been diagnosed with a disorder, but a careful search through both branches of the family tree is likely to uncover the source. Here's how in medical charts we document family trees or a family history for a particular trait or illness. In our records, we represent females as circles and males as squares. A solid line between a square and a circle represents a procreative interaction. The resulting squares and circles are the offspring. In this case, both a daughter on the left and a son on the right involved in their own procreative relationships and created their own offspring, etc., etc. As we've said before, thyroid eye disease most often behaves as an autosomal dominantly inherited disorder, but with variable penetrance and variable expressivity. I'll explain these last two terms. In this 4-generation family tree from a real patient of ours, yellow signifies that a person had full-blown thyroid eye disease, and the graded black to yellow indicates individuals who had very mild forms of the disorder. As we've said, autosomal dominant inheritance means that each child of someone who carries the gene for the disorder has at least a 50% chance of inheriting the disorder. So roughly half the offspring of an affected individual shows the disease. Variable or diminished penetrance means that not everyone who has the DNA required for a disorder will actually show the disorder. There are several reasons why this may happen, such as the presence or absence of environmental or epigenetic factors. Some people may carry the gene and not show any problems. A carrier of the disorder, however, can still pass the gene on to their children. In the family tree shown, the male square indicated carries the DNA handed down from his mother, and then in turn passed this on to his daughter, but he doesn't show the disease. Usually, penetrance is expressed as a percentage of people who will show the disorder when looking at a large number of people who have the genetic predisposition. For example, we might say that a disease has an 80% penetrance, meaning that 8 out of 10 people who have the DNA show the disease, but not everyone. So the penetrance is diminished from the expected 100%. TED is thought to have so-called variable penetrance because thyroid eye disease is not just one disorder, but a group of disorders caused by a number of different autoimmune antibodies, each of which may have its own penetrance. Variable expressivity means that some people with the same disorder will show one set of signs and symptoms, and others will show another. And these may all be expressed at different degrees of severity. For example, some people with thyroid eye disease will show changes in their eyelids, while others show changes only in how dry their eyes are, and still others may show changes in both. Variable penetrance, variable expressivity, and the fact that males are more likely to carry the DNA and pass it on than show the disorder can make the following thyroid eye disease within a family a little confusing. Most often, if a person has thyroid eye disease, but they don't know where in the family it came from, it probably came through dad. Remember, men tend to carry it and not always express it. What determines who gets thyroid eye disease? Well, we've discussed how people with thyroid eye disease need to have a genetic predisposition, and that it appears that in the majority of cases this is inherited from one or the other of their parents. On the other hand, it's possible, of course, that a spontaneous change or mutation in the person's DNA can lead to the same predisposition. Regardless of the source, it seems clear that there is probably a requirement for specific DNA for the disease to occur. However, not everyone with the specific DNA gets thyroid eye disease, and we think this is in large part because there have to be environmental factors that unleash the disorder. Let's talk about those. Some of these environmental triggers are already recognized. It's important to remember that associations are different from causes. Just because things happen together doesn't mean that one causes the other. For example, there's a clear association between wedding cake purchases and subsequent pregnancy. Clearly, one does not directly cause the other, but they seem to occur in association. Too much or too little iodine in the diet seems to be a trigger, although too much iodine in the diet is more tightly associated with the development of thyroid eye disease than is too little. In areas of the world where iodine intake is greater, thyroid eye disease is more common. Periods of spontaneous remission, that is, correction of thyroid hormone abnormalities and or cessation of actively changing thyroid eye disease, are more common in the presence of low iodine intake and less common in the presence of high iodine ingestion. People on iodine supplementation are more likely to have episodes of reactivation of their disease. As we discussed in the first video section, the thyroid hormones T4 and T3 both depend upon iodine atoms, so perhaps an impact of iodine levels is not so unexpected. In the US, since 1924, iodine has been added to commercially available table salt. Some people think they will avoid iodine by eating Himalayan salt, but this contains iodine as well. Other dietary sources rich in iodine include seaweed, and most seafood, yogurt, turkey breast, eggs, navy beans, potatoes, strawberries, and cranberries. Viral thyroiditis caused by a virus that creates inflammation in the thyroid gland has been associated with the onset of thyroid eye disease. Even thyroid cancer has been associated with the development of thyroid eye disease. In addition to iodine, other ingested substances, sometimes in excess, but most commonly in deficiency, have been associated with the development of thyroid eye disease. Selenium plays an important role in the enzyme that creates T3 from T4, and also in the overall oxidative protection of the thyroid gland. Estrogen and progesterone levels play an important role in the development and severity of thyroid eye disease. First, although the predisposition for thyroid eye disease is autosomal dominantly inherited, with DNA being passed to males and females at equal rates, females are 5 times more likely to develop TED than males. In our practice, we have also shown that if a person has ever been on hormone replacement therapy or birth control pills, they are at greater risk for developing thyroid eye disease than people who have not. In a retrospective, case-controlled study in our practice, we found that the prior use for at least 6 months of birth control pills or hormone replacement therapy after menopause more than doubled the risk for developing thyroid eye disease. If a person is taking these hormones, we have not looked at whether or not there is a benefit to stopping the medications. Thyroid eye disease is more common around the times of puberty and menopause in women and towards the end of their pregnancies. Obesity, where fat cells produce estrogen analogs, is associated with thyroid eye disease. And we have to be aware that estrogens surround us. Estrogen is found in many beef products where animals are fed growth-stimulating hormones. Some pesticides and foods, such as soy products, which are now becoming ubiquitous in our foods. All food for thought, pun intended. A final issue deserving mention is unmonitored testosterone supplementation. We now have over a dozen male patients who develop thyroid eye disease shortly after being repeatedly given large doses of testosterone. Testosterone in excess in the body turns on an enzyme called aromatase that converts testosterone to estrogen. So in effect, these men are all being given estrogen. Stress is tightly linked to thyroid eye disease, both development and severity. The stress may be physical, as in traumatic automobile accident or surgery, or it may be psychological, as in the loss of a loved one or the increased demands of a new job. Smoking has also been clearly associated with the development and worsening severity of thyroid eye disease. First-hand smoke exposure is a person with thyroid eye disease who is themselves smoking. Second-hand smoke exposure comes from being in the same room with a smoker. Third-hand smoke exposure comes from a smoker having smoked elsewhere and then sitting next to someone with thyroid eye disease, and the toxins exude from their clothing. Even third-hand smoke exposure has been associated with thyroid eye disease development and exacerbation. Not all triggers or environmental factors associated with precipitating or worsening thyroid eye disease have been fully worked out. In fact, many of the associations that have been described are just that, associations, not clearly causative factors. However, if we go back to this chart from Section 1, Video 4, it is intriguing to see how many of the factors that decrease the production of T3 are believed to be involved in the development of thyroid eye disease. So why might decreasing the amount of T4 conversion to T3 precipitate thyroid eye disease in someone with this DNA proclivity for the disorder? We know from Section 1 that a decreased T3 level will increase TSH production. Therefore, it is tempting to suspect that the common result of decreasing T3, namely increasing TSH, plays a role in at least some forms of thyroid eye disease. However, high levels of TSH are unlikely to be the only pathway to thyroid eye disease, since plenty of people develop thyroid eye disease who never had a recognized high TSH. The essential points to take away from this video section are: thyroid eye disease is very common, and it can affect almost anyone, although it is more common in females than males and more common with advancing age. The underlying risk for developing thyroid eye disease is inheriting specific DNA from mom and/or dad, since the genetics of thyroid eye disease seem to be an autosomal dominant transmission. All first-degree relatives of someone with thyroid eye disease have at least a 50% chance of having that DNA risk as well. Specifically, one might give thought to informing siblings and offspring of their risk. There appear to be many environmental factors that are associated with the development of thyroid eye disease, some of which may be causative. Some of these factors are known, but there are probably many of which we are still unaware. We have raised the question of whether decreased T4 and T3, in particular leading to an increase in TSH, may play a role in the development and/or worsening severity of thyroid eye disease, at least in some people. This is an hypothesis with growing support.